Hi, everybody, and thank you for joining the Realign Healthcare podcast. We have a great guest with us today, Ricky Sahu. Ricky, welcome. Let's start by talking a little bit more about your journey so far, how you end up in doing what you've been doing, because at least to my knowledge, you're doing at least second pretty impactful startup in the healthcare. So how did your journey start?
Yeah. Thanks for having me, Henny. It's great to talk to you. So I guess I came into health tech really through tech. I went to college right when the iPhone was coming out, and that was the first time I really understood you can, make games and be on the computer and make money at the same time, which was pretty interesting as a college student. And then after that, I worked at Google, uh, which is obviously really deep tech, and then started to join some startups. I ended up getting into health tech because my wife is a doctor, and she was always sharing with me how, bad technology is in healthcare. And then, you have Google and Facebook and all these other tech companies, which are, let's just say not helping cure cancer necessarily. And the technology is so much better. And I really wanted to bring that scale and ability to the healthcare industry to use all of that prowess for much better things. And I ended up joining a company called Care Journey, which was founded by Anish Chopra, who I think you'll have or had on your podcast as well. And that really taught me a lot more about the healthcare industry specifically and how tech intersects with it, and not just health and tech, but also policy and the regulations. And during that time, I learned about this new spec called FHIR, which was, most of your listeners probably have heard about now, but, about 8 years ago, or I guess like 10 years ago, it was very little known. And it's kind of crazy that it's been that long now. And started working on FHIR related work back at Care Journey. Ended up moving up to Boston following my wife's, uh, doctor residency track. And remote work was not what it is today, and ended up starting One Up Health to focus on FHIR data interop, similar to like how Stripe and Twilio support interoperability for application developers amongst financial and telecom industries. I wanted to do the same thing for healthcare.
That's great. So a lot of this is started as a shared frustration that you heard every time you came home from your wife saying, why I cannot do the same in my goddamn medical records in the same way I can do it in Google. And it's great that it's created a lot of these opportunities. So right now, you're starting at yet another company with GenHealth AI, where you guys are solving for new generative AI technologies for the healthcare. How did it transition from FHIR? Because the FHIR problem is still not solved by any means,
Yeah.
right? And yes, I remember vividly when people could not spell fire, and now everyone at least can ask the questions at FHIR compliant. But now you're switching to another relatively new and very fastly paced environment. So, what kind of the problem do you want to fix with your new things? Is it also driven by the experience your wife, now practicing physician, has, or something that you learned on your previous startup?
Yeah, I mean, I think it even predates both of those actually. And it really comes from working a lot in like the machine learning space, as well as uh, working with massive amounts of data. And I think, I'd always been building kind of machine learning models to run predictive analytics and all kinds of stuff before I even got into the healthcare space. And, you know, I took neural network classes in college. So, really early on. And what you've seen over the last, 3, 4 years, really, really like even 3 years, is this crazy ability. for this new architecture from neural network transformers, which are building on top of other sequence to sequence models that have really transformed compute. It's basically giving us all like the capabilities of a superhuman on our phone that we wouldn't have even imagined 5 years ago. And all it's doing there is really predicting the next token. So in text data, you have, a sentence or a paragraph or an article, and there's a whole corpus of text on the internet. You can train these transformer models just like you would have LSTMs, long short-term recurrent neural networks or recurrent neural networks or convolutional neural networks with these next token prediction sequences. And what we saw with the early GPT-1 and GPT-2 models was that they were exceptional at predicting or playing out, the next sequence of events in these text sequences. You were able to write essays that were, now seem kind of quaint, thinking back with what you can do today. But like, if you looked at what long short-term recurrent neural nets could do, or like the classical statistics based natural language processing, it was not even close to what these transformers can do. And, what we were doing at One Up Health was really working on aggregating all this data for the purpose of organizations to be able to build applications and analytics on top of it. And yes, that problem hasn't been solved completely, but the data has been far more commoditized than it was before. And the interaction and connectivity is orders of magnitude easier than what it was before. So the problem has really shifted from, getting access to the data to now there is a lot of data. What can you do with it? How can you help me make sense of that? And that's a very similar problem to what happened with the internet and search, and now these large language models where there's so much information out there. How can you use these AI models to make sense of it? So we took this same approach at GenHealth as like, OpenAI does with large language models. But instead of training on text data, we effectively are training on medical event data. And what I mean by medical events is things like a procedure or a condition or a medication being dispensed or a patient's demographics and the sequence of events that under which those unfold. So now you have a patient rather than like a web page as the entire sequence that you're training against. You now have something like a patient's full medical record from, the first encounters or enrollment on a health plan or like birth or whatever it may be, all the way to all the things that have happened to them today. And the tokens, instead of being words or parts of words, become these codable concepts, which are all embedded in FHIR and HL7 and CCDAs, all in the EHRs or in claims records. But we've codified that in these structured ways that you can with FHIR and with healthcare standards. And we're not doing what everyone else is doing, which is using the natural language text. And it's a bit of a double-edged sword there because there is a lot more detail in some of the natural language that like a provider might submit as part of the patient's clinical record. But you also don't have the longitudinal information that might be contained. And you also don't have things like the cost of an event or the NPI or provider and those sorts of broader structured elements.
That's very cool. So let me repeat if I get it correctly. Instead of using traditional words, that's a classic LLM that we see everywhere, like ChatGPT right now, you extracted a lot of those codable events that we see in the medical chart and decided to create your transformer and your model around that. So instead of predicting next word, you're predicting what's going to happen with a patient trajectory. And
Exactly.
and that's allow you to see where you can go from preventive care perspective, where you may go from the care perspective. Who are the current users? Are you bringing it mostly to clinicians who trying to work on pop health and identify patients who may benefit from intervention X? Or are you mostly working on a different side of the cost equation with payer or maybe ACOs?
Yeah, so it's really across the board. Again, similar to like the GPT models, which can be used to create a chatbot, or it can be used to create an application that can help you write essays, or it can be used for, you know, question and answers, like for the USMLE exam. Similarly, our large medical model can be used for things like referral management or next best action, or creating a digital twin of a patient, or creating a synthetic data set, or running population health analytics or prior auth automation. So there's a broad variety of use cases that you can meet with what we call a large medical model, just like you would be able to meet a broad variety of use cases with a large language model. And I think the difference really is that because you're able to structure the data, you can then enter in healthcare in a much more specific way than in, like, let's just say language. We are able to interact with the data in ways that you wouldn't be able to with just language based, text based LLMs. And you can do things like determine the total cost of care of a patient over the next year. And we recently released a paper that evaluated our performance against all of the existing models, both classical and against like LLMs. And the LLMs, if you give it a patient record, it will tell you the total cost of care of this patient next year is going to be whatever the cost of care last year was. And that's like a good naive, solution, but it's much worse than even things like the HCC score or other commercial models. But what we were able to do with a large medical model is double-digit percent better than any of the alternatives out there in the market, and better than anything in research. So it's really a big difference, kind of taking a healthcare native approach to transformers.
That's great. And do you think it's because ultimately language-based models are still working with the text, and we assume that's a lot of the knowledge encoded in a text, implied knowledge in this problem, but it's not always is, right? Like you spend enough with the medical records, and certainly as a practicing physician, you see these records where you have to guess, and note was less than perfect. So knowledge may actually be encoded in many elements, not just in text.
Yeah,
So,
exactly.
so do you think a lot of this performance is because you're using a different concept? And if someone will start right now, potentially just using traditional LLM architecture, extract medical concept, for example, identify something in a more it's still language version of this, right? But instead of just going out of the bulk of the text, identify the concept and then kind of bulk them together. Do you think they may be able to recreate to a certain degree the flows you have, or it's just like fundamentally different way to look at the problem?
Yeah, I mean, it's pretty fundamentally different. It's like akin to the way we think about it is like there are different modalities in, uh, these generative AI models. You have the language modality, you have images, you have sensor data, you might have DNA, and then you have what we have, which is medical events. And there's overlap across all of those, right? You can represent, DNA as an image or language as an image, similar to, medical chart as an image. But if you have this specific vocabulary, you will have many benefits. One is like, beyond, let's just say, the data, the biggest thing is like the compactness with which you can represent a patient's full medical history. And as you're probably aware, like these large these like transformer based neural networks, they really function on the attention and the recency of previous events in the sequence. And by doing that, and by keeping things more compact, you don't have to look back as far in the sequence in order to know that the patient had X, Y, or Z condition. And so that's one big piece. The other big piece is that we're able to codify things like cost, which are not so easy to do or not as specific with language models. And then finally, things like provider NPIs. So if you were to just give an NPI to a language model, it's not, and you can try this out in like ChatGPT, it's not going to know who that provider is. And if you were to say, the name of the provider is Taylor Swift, it will get a little confused. And it doesn't have that punch in the amount of information per token because we're able to structure it in a way so that an NPI always means this NPI. And there's no, Taylor Swift doctor is equal to, Taylor Swift, the musician.
I see. So in essence, knowing that we're so focused on attention, you're decreasing the noise in the system and
Yeah.
allow the system to focus on a particular type of the data and information. That's very cool. And frankly, that's back the question because now you mentioned this different type of modality of the model that's would be coming. Do you think the future is general, aka the big boys, OpenAIs and Meta, will keep growing their Uber models that may kind of get proficiency with their multimodal stuff, versus like not really small, but smaller, more focused and more noise-free model. That's what you're building will still be better in expert opinion and potentially maybe integrated into this big Uber models.
Yes, I think it will end up being very similar to like the different, let's just call it lobes of the brain or, different functions within the brain. And you will have these finely tuned models that are specific for interacting with some modality. Let's just call it like, for example, the eyes, you're right. You have a whole part of your brain that are specific for vision. And that's finely tuned to accept that vision input. Similarly, you will have, um, purpose-built models like the ones that we have that are exceptional at processing medical events. And the language models will never be as good at doing that. However, you can basically fuse uh, the purpose-built models with a language model, with an image model, with something else more broadly, and have the best of both worlds. And that's exactly what we're doing. So we're taking, the off-the-shelf language models, and we're, uh, you know, connecting them to our medical model so that you can interact now with all of the, benefits of the medical model, but using natural language text. So you can ask it things like, who are my patients that are the ones that are most likely to have type 2 diabetes in the future? And it will uh, use both cached and on the fly interactions with our model to give you that data and those results back in natural language text. And you can also then do much more complicated things like, um, you know, for things like quality measures, like tell me all my, tell me what percent of women are likely to have, osteoporosis screening next year and are between the ages of like 65 and 75. So like that sort of interaction with a language model, it's just not possible. Um, and then you can dive in deeper and say, who are those women? How much will they cost? Which ones are the ones that are the most likely to actually have osteoporosis? Give me a list of them so I can reach out to them. Those sorts of interactions, which are not really easy, kind of impossible with just language models.
This is wickedly cool. I have to admit, right, as CMIO and CIOs in the world and chief data officers, it's a mixed bag because on one hand, it's super excited. Oh, yeah, I can start doing all these incredible things. On another hand, for the first time, maybe you start to now think yourself about the job security because honestly, whole CIO, CMIO offices were created because operational and clinical executive wanted to answer these questions, and there is no way for them to answer these questions. So they created the office that can help them to facilitate. So now, if by using different type of the models, one or several, they can start, maybe our IT office go down in size. Like, how do you see the future?
Yeah. So I think that right now, a lot more time is being spent on answering the questions. Like it would take you weeks to get to the answers that I just mentioned uh, around on that chain of thought. And we can literally do that in like a minute, like of interaction. Um, but what you can now do is take those same people and actually get them to help act on that information and actually do something to improve patient care. And I think that's where it's going to shift. It's going to shift more from building, specific bespoke queries or analytics or models to answer a question into asking a question, getting the answers, and then taking action on that data. And I think like one of your earlier questions was like, who are the people that we are interacting with, like from a who are the people that are using this? So it is like the chief data officer teams. It is also the CFO teams. It's also the chief medical officer organizations. And more specifically, we're building applications on top of this to help support very specific use cases. Not because like we're not interested in other use cases, we are, but like these two, one which is around pop health analytics, and two which is around utilization management and prior auth automation. Like those two are quite acute needs in the industry and are really things that can be improved upon significantly and really disruptive in the market using this sort of transformer based approach.
So for all of you clinical folks who are listening to this episode, maybe it's not the best time to start learning SQL, and maybe it's time to start learning how to use a lot of this tool and actually go back into the bedside and start helping deploying and using those tools in production. So when you look at your first partners, right, is healthcare insurance high-fiving you for bringing them the fast tool that's allow them to predict what's going to happen? And if so, like as a physician, I have a concerns because to a certain degree now when you can predict this on big scale, ultimately everything you do on a big scales, you have a possibility to be wrong. And I think it's possibility, not just certainty. So how do you ensure that A, they do not act on incorrect information that may ultimately affect the way we deliver care or the way patient potentially having access to care because you may be denied
Right.
acceptance to ACOs or even have a higher premium?
Yeah, so I think, yeah, obviously you have to be very careful about how you approach this. And I think like taken to the limit, more and more dollars are going to be directed by AI in healthcare than they are today. And it will end up becoming the majority, whether we like it or not. And even if like Gen Health were not to exist, I think like this arc of AI is not just happening in healthcare. It's like happening across really humanity and the way that we think about evolution. And in some ways, it's like an inevitability. So I feel like the right way to think about it is how do you construct these models in a way where you have enough information to act on them in an educated manner. And that's the way that we're approaching it. And we've made these models far more inspectable than what's kind of available out there today. These are like these, people think that large language models and AI is really a black box. It's very much not. Like, there are so many attributes of the model that you can inspect to tell you how important certain features are, or you can simulate alternative futures by changing parts of the patient's history. Just like, for example, with a language model, you could do something like the dog is big and blank, right? And the language model will return to you something like fluffy, hairy, slobbery, whatever it might be. And there are a few properties of the transformers that apply here. One is called the attention weights, and that tells you how important are all of the elements that you put on the input prompt. So the dog, big, fluffy, right, is, the and is probably are less important than dog and fluffy and big. And it'll give you a numeric value to those. So very similarly with our large medical model, you can take in something like, you know, female, 6 to 7 years old, type 2 diabetes, metformin. And then the large medical model will tell you how important is it that they're female versus type 2 diabetes versus metformin, et cetera. And then you can alter those inputs and basically say, well, what if I gave them, semaglutide instead of metformin? What does that do to the attention weights? So it'll tell you that. It'll also, you can play out the future and see how different is that future relative to the, metformin future. Similar to how you would change it, to the dog is big and, blank, you could change it to the cat is big and blank, or the dog is small and blank, right? Like, that would change it quite drastically. So those sorts of things are really inspectable. They're just not made publicly available through like the interfaces that people are interacting with, like ChatGPT, because it's a bit too much information. But with healthcare, those sorts of things are important. And I think what's going to end up happening is like people are going to basically look at those, they'll want to know, and then over time they'll build trust for these models, at least in which use cases they're good, in which use cases they're not. And then after that initial trust is kind of gained, people will kind of go about their daily lives and just prompt it and get the responses and, move forward with that.
I like your example on metformin and GLP-1, and because GLP-1 relatively recent, and how many observations do you actually need to start shifting this attention? Because I imagine when you start with a limited amount of observation, most of your model will still point to metformin, only because that's what they see in the data. But for many patients, I think we see more of a GLP-1. So are we talking about hundred thousands, thousands, or way less? When do you start to see the model align?
Yeah, so GenHealth, we've trained our model on about 140 million patients across the US population, covering commercial, Medicaid, and Medicare populations, all over the US. And that is a big, benefit, like just being able to train on that population of data. But when you're simulating a future, basically the model is not telling you what is the best path. It is telling you, like you said, what is the likely path. So if we've never seen GLP-1s, then it would never predict it. We have, so it does, and it will predict it kind of based on the proportion. But what you can do is you can basically simulate alternative futures by prompting the model with the same exact patient history and then tacking on metformin or tacking on this GLP-1. And then, play out those futures 100 times each, 10 times each, whatever you want, and then look at the outcomes in that probabilistic distribution of what's likely to happen under those two different scenarios. And we've done some math on this. Basically, we see that about like a 50 count Monte Carlo simulation, so 50 potential futures, gives us, you know, state of the art results on predicting total risk and cost of care. And of course, you can do more than that and get more specific. And maybe if you want to like look at some side effects or something around rare diseases, you need to do more. But the cool thing about this is you don't need to involve any human in that simulation. You just put it into the model in silico, and it takes, maybe a minute or so to run. And you have, a few hundred potential futures for this patient to go down. And you can add up, because we're like working with discrete data and not just like words, you can add up all of the diabetic and kidney related events for both, future simulations. And you can see, oh, there are higher diabetic and kidney related events on X versus Y. And we've actually done this with metformin and semaglutide and um, alternatives like gastric bypass surgery and like diet and exercise counseling. And what we actually find in our model is that semaglutide and metformin are pretty similar for like older male patients. That's like the only one that I've investigated this in. Um, but diet and exercise counseling beats all of them, which is quite interesting. And it's a little bit better than the actual heart bypass surgery, which beats the medication alone.
Wow. And is it your model currently available to patients or only to professionals? Because I
Yeah,
imagine from the patient perspective, I would like, we're already doing financial planning. And yes, you come to the doctor and doctor will educate you about diet and exercise. And maybe you will listen, maybe you will not. But this is a very visual tool that's allow you to actually not only plan your healthcare as your wellness part, but also estimate your spend if you do nothing, or if you keep
yeah.
doing your favorite burgers, or maybe if you go and keep jumping from this bungee rope. So, is it available to patients?
Yeah, so it's available in two ways. One, and it may not be so easy for patients, but one is via an API, and two is via a application which we call G mode, which is for chatting with the data of a population. So it is available, but we haven't really made it so easy to use for individual patients, mostly because we just have a lack of time to address all the use cases. But the API, we hope that people will interact with that and build patient facing or provider facing or other user facing applications for the multitude of use cases that you can support.
That's great. So all the innovators who are listening may actually go get access and start building and experimenting with your API. It's already
Yep.
available.
Yeah,
Oh, that's
exactly.
perfect. Great. So where do you think a lot of this application will lead us? Because we talk about the realign healthcare, and what we see right now is insurance premium continue to go up despite all of our best efforts, and physicians are more burnout than ever. So it's pretty much doom and gloom, no matter how you look. So do you think a lot of stuff we are doing right now will help break this trajectory? And if you do feel this way, that it's help, how? Like, what can we do differently to kind of get off the spiral?
Yeah, totally. So I think it'll definitely help. And it'll help in many different ways. And I believe like this sort of technology um, will probably be at least like a 10-15% impact on the cost of healthcare over the next, you know, 10 years or so. And it will take time for it to percolate into the variety of use cases, but there's no question that it will both reduce the cost of care and improve the quality of care. And I think like there are many incentives in the industry where the need for this technology is already aligned with like the economics. But I think it'll take people building this in as like a last mile solution, not just like what we've done so far, which is an API and a couple apps, but it'll take people to build hundreds of other applications on top of both the, large language models, but also the large medical models. And I think, I believe like there's a couple of different ways to look at it, right? The large language models are good at doing what humans do, but with, let's say, more efficiencies. So I think that can cut down a big chunk of the administrative burden in the industry. Um, but it's not going to be helping us make better decisions because they haven't seen, things like I mentioned earlier, which are like cost events or which provider is better or which medication is better. They've been trained on publicly available data. So you're only going to get answers for things that people have already discovered. What our large medical model is able to do is it's able to synthesize kind of the latent information in these 100 million plus patients, and we're able to come to conclusions that have never before been published. And I think those are the ones that are going to shift a bigger portion of like the healthcare journey. So for example, with like something like prior auth automation, right? You can automate the prior auth process using this technology. And we're able to go from like about 17 minutes for reviewing a prior auth that's submitted to about 3 minutes, for that submission. So that's great benefit. It's probably a few, $100. Let's just take it for that one interaction. It's probably like, you know, $10, $15, something like that for that one interaction, maybe like 30. But what you're able to do with these large medical models is you're able to simulate a patient's future if they were to have this procedure or medication versus if they're not. And you're able to play out the future and look at the total cost of care as well as the outcomes. And you can see there's certain situations where there's a win-win-win where the medical policy would say, deny this patient care. But if you simulate the patient's future under that denial, it actually ends up costing more than if that procedure were paid for and approved, because there are longer term consequences with some sort of readmission risk or some high likelihood of being admitted to the ER. With our model, you can kind of see those and add up the total cost. And you can then, the plan could effectively choose to approve that procedure or medication to abate that cost. And the plan will end up spending less money over the next 6 to 12 months. The provider will get paid and the patient will benefit. And those costs are like thousands of dollars rather than just like tens of dollars on the administrative burden side.
To be honest, I almost can feel excitement from my life science colleague and potentially even digital therapeutic colleagues, because it's been an uphill battle for them to get approval and get into the approved registry for a lot of the payers. So do you think this approach truly can make it accessible, some of the previously unaffordable therapies that we currently may be doing one off because it's just so expensive?
Yeah, totally. And I think like, um, a lot of times both clinical trials and these clinical practice guidelines, the way that they are constructed is you have a handful of patients, sometimes like a couple dozen patients that the trial runs on or that like this research is done on. And then they find some positive result and they're like, now let's do this for everyone in the US at least. And that is probably not the best approach because you lack a whole bunch of variety of, the variability in the population that may not, perform as, that these like interventions may not perform as well for. You might not have certain demographics. You might not have certain regions. you may not have certain other chronic conditions or comorbidities. And oftentimes these, um, cohorts or like these patient populations are selected to be very clean so that you can just get to the answer of, is this good or is this bad without any confounding variables. But like in the real world, those confounding variables are where you actually see whether or not something performs or doesn't. And what we can do with these models is you can basically simulate those interventions on a much broader population. And there might be cases where a certain med is good for a population, but is really bad for someone else or some other group that is just not known because it wasn't run in the study. And so what you can do now is you can basically create, let's just call it a digital twin or synthetic clinical trial, where you can simulate the administration of, 100 different drugs or therapies on thousands of patients of varying, genders, ethnicities, geographies, comorbidities, et cetera. And again, you can do that in minutes without ever interacting with a real human. And then you can take those and hone them into which cohort, benefits the best from this drug. What condition was it for? What, population is it? What demographics do they have, et cetera? And then you could actually run a real human clinical trial on that population. And what that does is it cuts, you know, thousands of orders of magnitude of the analysis and, clinical trial work, um, and allows you to really, you know, put people into the things that are, much more understood even before like they were ever touched with some, med. So yeah, I think it will both broaden the accessibility of drugs and therapies that have never made it to market because you'll be able to simulate those on other conditions and patient cohorts. And from like a government pharmacovigilance perspective, it will help alert us to those populations or those use cases where you don't want to apply certain therapies that are already out there in the wild.
Sounds as a very powerful tool for clinical trials. Do you guys currently use real world evidence, or you just use whatever events available in the more classic medical records and the billing?
Yeah, so we have real world data, from this 140 million patient population. It is the actual events that have happened to those patients. We are training on anonymized data because there's like a whole privacy and security aspect of this that we can talk about. But just like you can ask a large language model like trivia about like some celebrity, which person has acted in these movies and like lived in this zip code, et cetera, and it'll tell you the name. If you did that same sort of thing with a large language model and you actually trained on the names and the addresses of people, which we don't, you would be able to re-identify, those individuals. So that's something that's we, take very seriously and, make sure. But anyways, like, yeah, like there are many different kind of like properties of these models that are still yet to be explored across like the clinical trial realm, across like the payer and provider world, in government, et cetera, that I would be, that we're learning about. But I think like many others are going to be needed to really see the power here.
Because we started talking about the risks, let's go a little bit more, on the regulation path. Who do you think it's responsibility to regulate? Is it something that every healthcare innovation lab and entity should do themselves and just follow the best practices currently available? Should the government go into the process and say, here's exactly how we want it to do, or smaller lab, maybe at academic medical institution or organization like CHAI, for example, need to come and become this guiding lights about how do we test, how do we validate, like what camp you're in?
Yeah. So I think like the farther you move away from like actually doing the work, the less you know about both the risks and the benefit, and the worse, let's just say, the guidance will be. And that doesn't mean like we shouldn't have those people thinking about it. It just means that they need to be as educated as possible and be closer to building of these models if they want to do a good job regulating it. And, uh, unfortunately, it's like a bit of a catch 22 because you can't do both well, right? Like you kind of have to focus. So I think it's like the responsibility ultimately lies on the organizations creating these models. Um, and publishing data and research that demonstrates to others how well they work, in which use cases they work, where they don't work well, what these risks are, all that stuff. And that's why like I'm bringing it up, but that's why we've also released some research that talks about the performance and all that other stuff. Uh, when we introduced this large medical model concept, so ultimately, I think it rests on like the shoulders of those creating it, like us. But we obviously want to help educate the market and make sure that they also understand.
Then if it's on you, right, and the similar innovators, then how do you ensure you guys just don't regulate it in a way that's beneficial to you,
Yeah.
and which raise several problems. One, you're not artificially creating some of the barriers for entry for new participants,
Mm.
because now you at certain stage and let's invent new rules for something that people
Yep.
were concerned when Sam Altman started talking about this. Uh, and the second part is like, how do you ensure you're just not regulating you in a way that's convenient? That's you
Yep.
truly looking on the broadest and the best way to do this. That's truly in interest of society and
Mm.
healthcare participants.
Yeah. So I think um, this is a bit easier in healthcare than it is in the um, you know large language model domain. And I think that's because of the, you know, goal largely, not always, but largely in the healthcare industry of helping people, live longer, healthier lives. And I think ultimately what's going to happen is that the buyers of our technology and like of other solutions in the space are effectively going to assess and vet these technologies to understand how they do certain things like um, you know predict various ethnicities, um, or like protected classes, better or worse than others, and they will be asking questions around responsible AI. And what we're seeing is that they are doing this. They have, questionnaires that they are, you know, asking us to respond to uh, before implementing these sorts of technologies. And I think that is where like the broader community comes into play. And, we can be helpful in helping guide some of those questions. But like, I do want to like, I agree, like, we may not have, the uh, developers of these tools may not have the same incentives as others. So you always have to have a bit of, you know, two organizations butting heads, very similar to what you have in healthcare with like payers and providers, right? You have health plans that want to incentivize more patients to be on their plan, but ideally spend less on their care. But if you spend too little, then you're going to be worse performance, and then people will go to other plans that give you better performance on your outcomes. Similarly, on the provider side, especially with fee for service, um, there is an incentive to maybe over care for an individual with things that may not be necessary, and you have to have this tug and pull on both sides to keep people honest, let's just say. And I think it's going to be the same with the market around selecting AI software in healthcare, where um, you're going to have checks and balances on both sides.
Check and balances, I love it. And with a very clear importance of technical knowledge and feasibility. And do you think we have enough right now in our ecosystem? Because it's interesting because when you listen pitch from any, I would say right now, company that doing analytics or large language monitoring, it pretty much sounds not the same but very similar. So, do you think right now, in this abundance of offers that's coming from a big player that's healthcare system and payers already have contract with, and small startup that's just trying to get, do you think there is enough technical knowledge and understanding in the system to actually make fair decision, or we kind of doomed to repeat some of the mistakes and just learn from, wasting some of our resources?
Yeah, I mean, I think the reality is it will probably be more of the latter, and it's always, going to be that answer for every new technology. And I think that's okay. Like that's, us as, a species, like interacting with things, right? You never know what you're going to get unless you try it, holistic, like fully. And then people talk about what worked well and what didn't work well, and then the knowledge spreads. But at some point, something has to be inspected before, and I think that's what's going to happen. But I do believe that these technologies are broadly better than what we're using today to make decisions, and therefore, like, I feel like people, you know, are maybe doing themselves or their patients a disservice by not moving this way faster because of some, you know, fear of, let's just call it the unknown, right? Or the newness. But what we've seen over and over and over and over in history is that new technology usually is better, and it ends up winning and it ends up supplanting what was there before, like the classical statistics based risk scores or analytics, or the, you know, a few people got into a room together and discussed this clinical guideline, and now every other health plan is gonna, codify that and put patients into denial or approval track for, what, like, maybe a couple dozen people have interacted with.
It's interesting when I think about the progress of the innovation. I often think about stuff that Taleb was talking in his book of Anti-Fragile, because ultimately, when we build anti-fragile system, we're trying to build a system that may still perform optimally when there is very new type of stressor, and aka the system is less fragile. But now we potentially creating these multi-agent systems that perform extremely well under well observed scenarios, but then may create this paradox of domino effects failures when you start to deal with something completely new, right? Like new pathogen, like COVID-19, for example, or something else. Do you think ultimately we are making our system more fragile in the name of efficiency?
No, definitely not. And the reason for that is, like, right now, uh, our systems are far more fragile than what these LLMs and these large medical models can do. And I'll give you a very specific example. So let's just take risk scoring from something like HCC or Milliman or Milliman's like MCG, Mara score, or things like Hopkins ACG or like Cotivity. So they all have these risk models which can stratify a population, but they can also tell you how much a patient will cost next year. And basically, like, every provider and plan uses these models in some way or another. The government uses the HCC score to set bid rates and determine how much they're going to pay a plan for some capitated risk model under, like, Medicare Advantage, for example. And those models are based only on the patient's demographics, their ICD codes, sometimes the procedures, and the past medical costs, and that's it. And they often don't even take into account all the potential ICD codes, which are like thousands of codes. They don't take into account all of the, meds or the doctors that you saw or all the other, events that you've had in your medical history. And we're spending, trillions of dollars based on these models. And, what happens if like a, ICD system goes down? Then you can't run these models and you can't predict risk as well. So what you're able to do with these large language models and our approach is like you're kind of able to just dump everything in there. It doesn't matter what the data is, you just dump it all in there, and the model will figure out based on what it's seen, when it's seen only a certain amount of data versus another type of data versus all of the data together, how the future will play out. And that creates a much more robust solution where it's learned the interaction effects between ICD codes or conditions and the procedures or the providers or et cetera. And when the ICD system goes down at some organization, you can still interact with this model and get better results than you would have otherwise. So I think that's a very specific example, but I think it's making things much more robust. I do think it's making us more dependent upon technology. Um, and I do believe that is a completely different risk, but it's less of a healthcare thing and more of a humanity thing, which I'm happy to talk about, which is interesting, but it's a little bit off, far out.
Maybe on another episode, Ricky.
Yeah.
I love it. Like, so ultimately, yes, it comes, a lot of those new technologies coming with the risk, but our current status quo is in such point where we're doing even worse than the system. So if anything, a lot of this helping us to make the system less fragile, not more fragile. Time flies. It's hard to believe we're almost at the end of our hour. And a very traditional question for the Realign Healthcare podcast. In your experience over the last decade on building FHIR infrastructure, interoperability infrastructures, and now working mostly in the generative AI health, where do you think and see the biggest gap in our alignment between all the main players in the system? And what can we do to bring it closer to close the gap?
Yeah. I mean, like, I don't think it's actually a technology issue. I think it's more of a um, policy issue, to be frank. And the main problem in my opinion, in the healthcare industry, especially the United States and really globally, is that you can't easily choose your health plan or who you want to be your, like your healthcare guide. In order to change your health plan, you either have to have a baby, get married, or change your jobs, right? Like that's pretty drastic. Like I don't have to do any of those things to change my car. I don't have to do any of those things to buy a different TV or buy a house or any of those, like I can do much more expensive and complicated things than healthcare with far less, uh, you know, change of lifestyle. And I think like, um, you know, the government is now enabling things like ICRA, which is like the individual choice of healthcare act, which allows providers, which allows your employer to pay for a patient, selected health plan, employees selected health plan. Um, I think, divorcing your employer is your health plan um, piece is really important. And we saw that happen with financial, the financial side where, people were on pensions and your employer was your retirement savings and all this other stuff, and that tied people to that kind of falsely. I feel like that sort of motion needs to go away sooner. And when that happens, patients will be able to move to a health plan that takes care of them better than what their employer sponsored health plan might do. And I'm not saying that they're bad. I'm just saying you can't change it easily because you have bad experiences with your plan or your network or, all of the things that flow down from that employer. So, yeah, I'd say like it's not quite a technology answer. The technology will help because you'll be able to, use this data and figure out which plan might be right for you or which provider would be best for this next, part of your patient journey. But if you can't, you know, shop around and, you know, talk with your feet, I think we have much bigger problems to solve.
Yes, and health insurance is certainly extremely sticky and extremely hard to choose, even despite all of our investment into relatively transparent marketplaces where it's very hard to compare what does it mean for me. Do you think, as a last question, that technology that we see right now may actually give birth to the newer type of insurers, or maybe new breed of concierge virtual or any kind of other care that's
Yeah.
maybe doing something closer to one medical that may not require this type of extensive and complicated process that we currently have for our insurance?
Yeah, I definitely think so. Right now, like there's not a lack of data, there's a lack of understanding. Like even health plans don't know which is the right provider that you should see for this condition. Like they give you a list based on either alphabetical order or distance based on geography. And then you have to select, which doctor is the best for you. And they don't even know. Like that's a huge problem. They don't know how much it will cost. They don't know all the other things that are going to happen in that event, and they don't know what the outcomes will be for you. So I think these models will help open up new, um, business models for health plans and even for providers that allow you to be much more informed and therefore guide that care with a level of understanding that is both going to reduce the cost and lead to better outcomes. And you'll be able to tell a person, hey, um, you can go to doctor one or doctor two or have procedure A or procedure B or medication, X or Y, right? Like you can choose between any of those. And we're going to tell you based on these models and your specific data and learnings from millions of other patients, how we expect this to affect you. It'll cost X number of dollars. You'll have these side effects. You'll have these outcomes, and you'll live, X many months or years longer. Like we can get to that level, how many days, months, years you'll live longer. And then the person can choose based on that. And maybe there is a dollar based incentive on how much you want to value extra years versus dollars spent. And I think like that's what it's going to come to at some point. Um, it may be a little weird to think about it that way, but I think that's basically the way that everything else in the economy works. And it'll eventually be like that for healthcare. Yeah.
People are not very rational, and certainly a bad judges of the current state. Would be quite hard for me to decide what's my true value and the cost of this family barbecue where I'm planning to eat a lot of a greasy food, especially on the long-term healthcare cost. But I
Yeah.
certainly like this future. So when you think about this future, what do you think is the biggest risk that may happen? Because like we didn't really spend time talking about the fire and everything that's happened was a meaningful use, but there is certainly a lot of the feeling inside innovators and technologists group that things could have been better, right? Things are not bad, but could have been more transparent and easier to work with and integrate with. So now, when we have this another opportunity to build new AI-enabled healthcare sectors, what do you think is the biggest risk we should try to compensate for to ensure we do not have any remorse 10, 15 years from now?
Yeah, I mean, I think there's two risks. One is that things don't happen fast enough. And I know that's like the opposite of what you're saying here in some ways, but I think there is a huge opportunity cost right now with people not being able to live longer, healthier lives because, um, people fear, like I was saying earlier, something that they don't know enough about. And I think like the education on this is not that difficult. Like, um, there is plenty of information. And once people are like, hear it once or twice, like they're like, oh, okay, yeah, I get it. Makes sense. Let's, move forward. And I think like can that is like not sharing enough data about it is going to slow people down because they are just going to feel like they're left in the dark, which is again why we wrote this paper, which is why we, you know, write, things on our blog about the different properties of these models, et cetera. We're really trying to educate the market so that they learn, understand, and can feel confident in that understanding to actually use this. If you don't know how to use something, and you don't have the information, you're going to be more reluctant to use it.
That's great. And hopefully we can start adding this as a mandatory education part to our schools and university, because we teach a lot of other skills, but we do not
We don't
teach
even have
you.
coding as a mandatory, part of the education, which is
But do you even need the coding in a 10 years from now? Can you just go to LLM and say, can you do me a React app that doing the following?
yeah. I mean, I think so you're right. Yeah, I think like in the long term, you kind of don't need anything, right? Like taken to the limit. You just, your wish will be, the desire, or like your desire will be like met by all of these AIs. And I do think that that will happen. But I also feel like where, there is a bit of a risk of blindly trusting things without having the base of knowledge. And that's why we're saying like you need to be educated about it because it's not going to get everything right, right? There's nothing that gets everything right. It may get things right more than humans overall, and maybe it will get things right more than humans on almost everything. But you still need to have some base of knowledge to be able to critically think and see, is what it gave you what you asked for, and not let it lead you down a path that seems like it makes sense, but like miss some critical, judgment.
To be honest, when I think about like risks from a clinical perspective, what you just described scares me the most, because we can talk about how proficient clinicians need to stay on the up-to-date knowledge and then capture the nuances of errors coming from AI, but it's hard. Why? Because when you do not do it repeatedly every day and you capture this, you lose your skills. And the concept of deskillization is real. And the
Mhm.
more we rely on something, the less we'll be relying on our own internal judge and our own skills. So less likely we'll be able to capture that. So I already notice it a lot in text messages and social media posts and LinkedIn's and Twitter's, where you clearly see it being written by LLM. You
Mhm.
clearly see it, and you clearly see the people not capturing errors because sometimes and very often logic just doesn't make sense. Just like this phrase makes no sense. Sounds right, sounds intelligent, just makes no sense. and people not capturing it, and that's not the main specific, right? So now, if you make it more complicated because you now need to analyze and condense tons of information to come up to this conclusion, I think it's easy for us to dream that physicians will be able to capture it. The reality, they will not. Like I think we may be setting up our physician for the failure if that's kind of the only way we can truly can monitor and correct our systems.
Yes, I don't think like it'll be like that. What I think the way that I'm saying it is like eventually, like within the next 5 years or so, these models are going to be better than the best physicians. And if they're not already. And the reason for that is like these have seen, 100 million plus patients. No human has ever seen that. They've seen how all of these variations in the medical record and the patient's journey interact with one another. No human can comprehend that. So then the question is like, if something is that good, then would you rather defer to that eventually, right? Because you kind of won't be able to come up with a better answer or more educated answer, let's just say. I think like in the middle kind of term of this, like between now and like that time, there will be a little bit more heightened, you know, interaction for humans. Where I'll give you a very specific example here again, um, around prior auth automation, right? So we can take a policy and a patient's chart and extract all the questions from a policy and answer them all based on the patient's chart. And we're doing that fully automated right now. And we are getting to, around 95% accuracy with those answers before a human has ever, looked at it. And then we still get a human to review those pre-filled out answers, um, rather than having to spend hours looking through hundreds of pages of PDF, where the humans are naturally already missing a whole bunch of information. So we're able to do that in seconds and now minutes rather than like, you know, the inordinate amount of time that people are taking. And we're basically just giving people a list to check rather than do it all based on their own. And that way you're able to get the best of both worlds. The AIs can automate all of the grunt work, and then free you up to do the kind of last mile check, but then use your time to actually help the patient act on that care. So that's the way that I think about it, is like the human still has the final say and the AIs are doing a lot of the let's just call it difficult, time consuming work with all of the explainability, citing sources, all that detail. And then the human can decide, hey, it was wrong here, or no, that checks out. There's a citation in the source. I looked at it with my own eyes, and then, act on those decisions.
Okay, this makes sense. So we are liberating our clinical staff from mundane data collection tasks. But then when we ask them to double check by using their higher reasoning ability, we give them guidance, right? But we don't expect them to know everything, remember everything, and recall everything.
Yeah.
We just give them necessary input information and want them to properly, as a professionals, to reason around that.
Yeah.
I
And
think
we, yeah.
that's would be way more impactful and
Yeah.
scalable than just expect physician to capture an error.
Yeah, exactly. Yeah. That's exactly what we're doing.
Perfect. Ricky, thank you for joining us. That's been an absolute pleasure. I really hope that when we talk next time, all of this would be already deployed everywhere in the future, because I really like the vision of the futures, and I just cannot wait when we can go around and easily switch our insurance, because now insurers do have very clear, predictable models that they deployed everywhere that can help them to decide that's first, people are healthy, people are deserve pay less premium and have access to better care.
Yeah. Thanks a lot, Henry. This is fun. And yeah, I'm sure we'll chat later.
Okay.